Assalamu alaikum wa rahmatullahi wa barakatuh. I would like first of all to thank Professor Hussein Al-Amin for these invitations. And my task today is tips and tricks in difficult ERCP cannulation. So these are my objectives. What is the definition of difficult biliary cannulations? And to review the ambulatory anatomy, discuss the standard cannulation techniques, and what is the approach to fail the standard cannulation, and we'll discuss some special circumstances. So cannulation is essential in ERCP. No cannulation means no ERCP. Even in the hands of experienced endoscopists, the failure of biliary cannulation can occur from 5 to 15%. The problem of the prolonged attempt associated with high risk of complication like post-ERCP pancreatitis, bleeding, and delay therapy. Now, if you will see the anatomy of the ampulla obvator, you can see what's very important to know is the vertical trajections of the common bile duct and the horizontal trajections of the pancreatic duct. And both of them, they join together into common ambulatory channels, and then they drain both together in the second part of the duodenum. Now, up to 15%, both of them, they can open separately. And that's really one of the very important things to keep it in your mind. And careful inspection of the papilla is very important. Sometimes you can see both opening separately. Now, the optimal point of first contact of biliary cannulations is the left upper quadrant. Before this, you need to have a good positions, and in order to have the proper cannulation. So if you want the common bile ducts, you need to go from the left side of the papilla with your sphincterotome and to hit the 11 o'clock side. Now, for the pancreatic duct, you need to go the other way around from the right side of the papilla and to go to 3 o'clock positions as a first touch for the papilla. Again, as I mentioned, the trajections is vertical, and make sure that your wire most of the times need to go parallel to the duodenum in case of the CBD, while it will be vertical in case of the pancreatic duct. Now, most of the time, we prefer the short scope positions because it will give you better movement of your wheels. But sometimes you need to go in long positions, and sometimes it can give you a better position for the papilla and the cannulations. And sometimes you need to change the position from the supine to the left lateral or left lateral to the supine positions. The standard cannulations, what we have is the contrast assisted, and we have the guide wire assisted. Now, if you will see, the guide wire assisted is the best way to take your patients because it has a higher rate of success of cannulation and less risk of pancreatitis. And this is for meta-analysis. You can see that the success rate of the guide wire is superior. And not only this, but also the post-ERCP pancreatitis, the guide wire is less in this complication. Why guide wire cannulation? Less traumatic, avoid contrast injection to the pancreatic duct, high rate of biliary cannulation, and low rate of post-ERCP pancreatitis. So what is difficult biliary cannulation? The European Society of Gastrointestinal Endoscopy in 2016 came with this definition: duration more than 5 attempts, or more than 5 minutes, or unintentionally cannulation of the pancreatic duct. But the international consensus in 2017, they increased the duration up to 10 minutes and 5 attempts, the same like the ESGE, and they didn't mention the unintentional cannulation to the pancreatic duct, but they mentioned that there is a failure of the axis of the major papilla. Now, what are the factors that contribute to difficult biliary cannulation? We can divide them into two groups: anatomy or patient-related factors, where you have a small papilla, papillary stenosis, tortuous papilla, diverticulum tumor infiltration by carcinoma, scope position, unstable positions, poor mobility, and sometimes increase in the contractions. And one of the really nightmares that we hated is the surgical artery anatomy, whether pillar 2 or Roux-en-Y. The other very important factor is the endoscopist and his experience. Not only this, but also I will put the endoscopy technician. You need to have a dedicated technician for doing such advanced procedures. Not only this, but also you need to know your accessories that gives you the answer in easy way. Charpy papilla is one of the difficult papilla. You can see the folds and sometimes very difficult to see the papilla. So what are the maneuvers to facilitate selective papillary cannulations in difficult cases? So we have the pancreatic duct assisted, we have the pre-cut, we have the EUS assisted, and we have the percutaneous rendezvous. Because of the time, we are going to focus mainly on pancreatic duct assisted and the pre-cut assisted. Now, the pancreatic duct assisted cannulations, when you are cannulating and your wire went to the pancreatic duct, leave it and then go with another wire to the common bile. That's the role of the pancreatic duct is to identify the ductal trajectory when you are cannulating. It occludes the pancreatic duct, and that might give you some chance to go to the common bile duct, and the other things, which is sometimes very important, it will straighten the papilla, especially if there is tortuosity in the papilla. Now, the pre-cut techniques, we have three main way: the needle knife papillotomy, fistulotomy, and then we have the transpancreatic pre-cut sphincterotomy, and we can do the pre-cut over the pancreatic duct. Very important to know your limitations and your boundaries when you are doing such advanced technique. Say, for example, for this papilla, if you would do the sphincterotomy, you can go from the opening up to C, where you have to stop. Now, the other way around, if you are going to do, if you fail, for example, for this papilla and you want to do pre-cut papillotomy, you need to start from the papilla and the stepwise fashion to go to the common bile ducts. For fistulotomy, you will start from above the papilla, and you can start proximally or distally. The most important thing is to respect the boundaries of the standard sphincterotomy, the path, the length, and the depth. So this is one of our patients, 85 years old, referred because of obstruction secondary to CBD stones. I failed to cannulate this patient, and then I shifted to fistulotomy. You can see the bulging is very nice for doing the fistulotomy for these patients. Again, you need to follow the boundaries of the cutting, and you can see the patient's, the pus was coming out, and the cannulation subsequently was successful. Pre-cut papillotomy with needle knife, again, you need to start from the papilla, and you need to go upward stepwise, and you need to, again, follow the boundaries of your bath cut. Now, this you can see, you can stop here and you can try with the probe, the guide wires. If it goes well and good, if no, you can again cut and to try again to access the common bile ducts. For these patients, I failed initial time, but after 2 days, I brought it again, and the cannulation was very easy. But the problem was the distal CBD was full of a stone, and even the balloon could not be retrieve the stones. And in this case, I used the basket to extract all the stones which have been impacted in the distal CBD. So one of the causes that it might be difficult with such impacted stones. Transpancreatic pre-cut sphincterotomy or septotomy or GOV procedure came by GOV in 1995. So the aim of this is to, if you fail to go to the common bile duct and your wire was in the pancreatic duct, you can go and do a sphincterotomy, a partial sphincterotomy. You can cut the sphincter, the septum between the common bile duct and the pancreatic duct, and also you can cut the ambulatory sphincter. So this technique is very useful, especially if you have a small papilla. The only thing is the bleeding and the pancreatitis is higher, and the ESGE recommend to put the prophylactic pancreatic duct whenever you do such technique. Now, what is the difference between all this advanced technique in terms of the cannulations? If you compare the transpancreatic sphincterotomy versus double guide wire, you can see that there is superiority of the transpancreatic sphincterotomy. If you will compare transpancreatic sphincterotomy versus needle knife papillotomy, again, transpancreatic sphincterotomy is superior. Now, fistulotomy versus transpancreatic sphincterotomy, both of them are equal. Thus, in terms of the cannulations, while the post-ERCP pancreatitis, transpancreatic sphincterotomy versus double guide wire, both of them are equal. Again, needle knife papillotomy versus transpancreatic sphincterotomy are equal. But if you see needle knife fistulotomy versus transpancreatic sphincterotomy, you can see that there is superiority of needle knife fistulotomy in terms of the pancreatitis. And that's why the ESG recommend to go with fistulotomy, especially if there is bulging in the papilla. What about the complications? You can see the bleeding are equal in both, in all the techniques. Again, the perforation is equal. Big diverticum is another issue that sometimes will give you difficulty. So for example, this patient, you can see the papilla, the opening was downward. So you need to go a little bit more closer to the opening, to the diverticum, and you can negotiate it with your catheter. Sometimes you can put clips in order to open the direction for you and to keep it more elegant for the cannulation. For these patients, with changing the position of the sphincterotome, you can see that we could cannulate it, and then you can readjust your positions, and then you can see lifting a little bit in order to have a proper trajectory, and then we succeed for the cannulation. Again, for the same patient, she is 85 years old with cholangitis, so we went with the sphincteroplasty, and you can see the big stones have been extracted by the sphincteroplasty. Ambulatory carcinoma is another issue. Whenever you have ulceration of the papilla, your suspicion of ambulatory carcinoma is very high. So the most important thing is don't take biopsy before cannulating such ampulla. The most important thing is again to go to the left upper quadrant and probing the guide wire. And most of the time you can succeed with some gentle pushing of the sphincterotome. You can see these patients with very gentle pushing and probing the scope, the guide wire, we could cannulate, and you can see the bile was coming easily. Not always ambulatory carcinoma is easy. So these patients, we tried to cannulate him, but I failed to cannulate these patients. So I went to the proximal part of the papilla with the pre-cut fistulotomy. Again, this part is soft, and that's why I prefer to go with such maneuver. And you can see downward directions, and then I tried to go proximally to the upper part. And then you can see the bus was coming out. And continue the cannulation with sphincterotome, and you can see the bus was coming, and the patient. After that, we put the stent, and after that we took the biopsy, and the patient underwent for surgery. So the ESG guidelines in 2016 came with this algorithm. If you have a patient with failed bile duct cannulation with 5 attempts or 5 minutes for the ESG, I prefer to put it 10 minutes with the international consensus. If no pancreatic guide wire was inserted, then you have 2 ways: fistulotomy or papillotomy, pre-cut needle knife papillotomy. If your wire was unintentionally went to the pancreatic duct, and then you can go with guide wire assisted common bile duct cannulation. If you failed and the ampulla is bulging, you can go with needle knife fistulotomy, or if it is small, you can go with transpancreatic biliary sphincterotomy. The most important thing for those directions is to put the pancreatic stenting, and that's the recommendation by the ESGE. So to conclude, ladies and gentlemen, understand anatomy. You need to be cool, especially when you have difficult cases. If you fail, then make the change early. You have to know your instrumentations: small catheter, short wires, hydrophilic wires, angled technique. Try to change it as soon as in early ways. try to go to the pre-cuts if you failed with the standard. And then you can call a colleague if you failed. You can bring the patient after 2 days. If you couldn't, you can refer to expert center. The alternative way is to go for EUS guided or PTC. Thank you very much.